Hi, everyone. Thank you for joining us today. We are just nearing 12:30 and the start of our media briefing, so I'm going to give a few folks a few more minutes to jump in, but we'll be beginning right at 12:30. Thank you. We're at 12:30. Hi, everyone. Thank you so much for joining us for the Liver Meetings media briefing. We hope to see a lot of you in Boston, or if not, there in person to join us virtually on site, or sorry, virtually on the digital platform. My name is Caroline Lauren. I'm the Vice President of Marketing and Communications for AASLD, and I'm delighted to have you all with us here today. Before we launch into the briefing, I want to just give you an overview of what to expect, as well as some housekeeping remarks. So if you look at the webinar screen, you will see a Q&A feature. We ask that you put any questions you may have in that Q&A feature and direct them to a speaker. We'll be opening it up for questions at the end of the presentations. So in order to make sure that we direct your questions appropriately, we ask that you let us know who you're directing the question to. If you have any questions that were not addressed during the meeting or didn't get a chance to ask, please go ahead and feel free to email me, and I will make sure I follow up with our panelists today and get back to you with those responses. And we're also going to make a copy of this briefing available to all registered media following the briefing today. So stay tuned for that email from me. So an overview of what we're going to discuss today. We have two abstracts that will be presented at the Liver Meeting, followed by some large big picture implication conversations, as well as a conversation about the MASLD nomenclature, which was passed this past June, or changed this past June. So first we will have a presentation by Dr. Phuc Le, who's the Assistant Professor of Medicine at the Cleveland Clinic, followed by a presentation on food insecurity and liver disease by Dr. Zubair Younousi. And then we'll hear from Dr. Nora Turo, AASLD's president, just about, like I said, big picture implications about the global burden of liver disease, followed by a presentation by Dr. Rohit Loomba on the NAFLD nomenclature. And as I said, following that, we're going to open it up for some questions. So I hope you'll enjoy our lively conversation today. Lots of great information that'll be coming your way. And feel free, like I said, to put questions in the chat as they come up, or in the Q&A as they come up, and we'll be sure to address them toward the end. So without further ado, I'm going to turn it over to Dr. Phuc Le with her abstract presentation.
Thank you so much for the opportunity to present our projections of the clinical burden of NAFLD in US adults from 2020 to 2050. Next slide, please. The study is funded by the Agency for Healthcare Research and Quality, and I have no other conflict of interest. So the prevalence of NAFLD has been increasing significantly, both worldwide and in the US. A recent meta-analysis estimated that 38% of US adults had NAFLD in 2019. So on several phase 3 randomized clinical trials to evaluate different potential treatments for NAFLD are either completed or underway. And the target population of these trials has been patients with non-alcoholic steatohepatitis and fibrosis stage 2 or higher. So a better understanding of the clinical burden, especially the size of the treatment-targeted population, will help our health systems to prepare for the growing clinical demand. So the objective of our study was to construct a natural history model of NAFLD to estimate the disease burden from 2020 to 2050 among US adults. To do that, we built an individual level state transition model. So it's basically a mathematical model that follows individual adults over time. So the model has two components. The first component tracks the growth of the US population, incorporating new births and immigrants over annually. The second model component tracks the natural history of NAFLD in adults with 14 different health states, as you can see in the diagram on the right. Patients will progress through these conditions over time until they die because either of the liver-related complications or other cause of death. The model inputs were derived from the literature, and unknown inputs were calibrated and validated against published estimates. And here are our results. So this figure shows the model projections of the disease prevalence. The orange bars represent all NAFLD cases. The green bars represent all NASH cases. And the height of the bars represent the number of adults. So our model projected that 27.6% of US adult populations, or 72 million people, had NAFLD in 2020, which would increase to 34% or 109 million people in 2050. Among these patients, 14 million people had NASH in 2020, increasing to 21 million people in 2050. Next slide, please. So these figures show the distributions of cases by fibrosis stage. In the figure on your left, which include all of the NAFLD cases, our model predicted that 16.3 million people would have fibrosis stage 2 or higher in 2020, which will increase to 25 million in 2050. In the figures on your right, that includes all NASH cases. Our model estimated that during the same time period, the populations with NASH and fibrosis stage 2 or higher would increase by 1.5 times, which means from 6.4 million people in 2020 up to 9.8 million people in 2050. Next slide, please. And finally, here are the results regarding advanced liver complications. So the figure on your left shows the number of new cases of liver cancer, which is the orange bars, and liver transplants, which is the green bars. Our model estimated that the number of new liver cancer cases would double, and the number of new liver transplant would about triple in the next 30 years. And finally, the figure on your right showed the estimated number of liver-related deaths in the next 30 years. We estimated that the number of deaths would increase by more than 2.5 times, amounting to nearly 80,000 deaths by 2050. So in conclusion, our model forecasts a substantial clinical burden of NAFLD over the next 3 decades. And in the absence of effective treatments, health systems should plan for large increases in the number of liver cancer cases and the need for liver transplant. And I would like to acknowledge my co-authors who make this work possible.
Thank you very much, Dr. Lee. And I'd actually just like to raise a point prior to moving on to the next presentation by Dr. Younasi, which is that, as I mentioned at the start of the briefing, we made a nomenclature change was announced in June, and we're still very much in a transition period. So you will see both throughout the meeting and today's presentation, the use of both NAFLD and MASLD, NASH and MASH, and that's because we are still in that transition period. So you see both, we've tried our best to make the changes where it is appropriate, but it was not always appropriate in all cases with previous research. So we hope that provides some clarification. And without further ado, I will turn it over to Dr. Younasi.
Well, thank you very much. Thanks for allowing us to present this this research. This is a oral presentation that will be done by one of my research team members, James Pike, on Monday during the on Sunday, actually, on the 12th of November, during the liver meeting. The project is titled Food Insecurity in Household Income Substantially Increases the Risk of MASLD or NAFLD among adolescent children in the United States. Next slide. These are my disclosures. Next slide. So to understand childhood food insecurity in the United States, which is part of the health disparities sort of surrogate. The food insecurity among children is about 10.2% in the United States. And it may be a risk factor. In fact, it's been shown a risk factor for MASLD among adults, but the data in children and adolescents is really missing right now. It's lacking at the moment. So our goal for this study was to look at the association between MASLD and food insecurity among adolescents in the United States. Next slide. We used a publicly available data set that's called NHANES database. That's National Health and Nutrition Examination Survey. It's carried out every year, and we chose the year 2017-2018. And we assessed food insecurity using a model and a question that actually is in the NHANES data set. And it's the one that the U.S. Department of Agriculture actually uses. We define MASLD or NAFLD by transient elastography, which is an equipment that uses ultrasound to determine the amount of fat in the liver, and this is the standard way to define MASLD and NAFLD. An amount of scarring of the liver, which is called fibrosis, is defined by again this transient elastography, and again with how much stiffness you see in the liver. Advanced fibrosis is basically pre-cirrhotic and cirrhotic, so this is quite a bit of scarring of the liver. And significant fibrosis is what we actually use to see if a patient is going to qualify for treatment in the future. It's called F2 and higher, at least that's the surrogate of that. Next slide. So when you look at the study population, there is about 711 individuals that had the question that you can categorize them in terms of having food insecurity or not. And when you look at those patients who had NAFLD by definition or non-NAFLD, these are all adolescents, obviously. Patients who were NAFLD patients or MASLD adolescents were more likely to live in food insecure household that had low income, and head of their household had lower education level. That's less than high school. And obviously, NAFLD, MASLD patients have more metabolic diseases, they're more obese, they have more type 2 diabetes, etc. And these adolescents relied more on low-cost food or did not eat a balanced meal. Next slide. About 19% of adolescents in this context who were identified as food insecure also were defined as having NAFLD or MASLD. Food insecure teens or adolescents had higher rates of advanced liver disease. That's, of course, by amount of scarring of the liver that was defined as we defined it earlier. There were no differences in terms of metabolic diseases such as type 2 diabetes and the two groups based on food insecurity grouping. Next slide. So this is looking sort of a similar data using graphs. Again, food insecurity was more common in girls and also in those who are between ages of 15 to 18. And this is important because this is where adulthood would start, and these adolescents will take these diseases with them to adulthood. Next slide. Now, a number of things can can contribute to this. Of course, so you have to control for what we call confounders. And when you adjust the model to see what is independently associated with MASLD or NAFLD, you see that food insecurity and low household income were associated. When you do adjust even more with demographic sort of components or components of metabolic syndrome, again, food insecurity remains very tightly associated with NAFLD or MASLD. Next slide. So we concluded that the association of food insecurity with MASLD is probably more likely the result of not being able to eat well or a balanced meal, and more likely having sort of the inability to purchase good meal and resulting in purchasing low-cost food. Together, these factors may lead to a cycle of overeating along with overconsumption of ultra-processed food and sugar-sweetened foods and beverages that really promote this important liver disease. Thanks again. Thanks. I'll be glad to answer any questions during the Q&A.
Thank you very much, Dr. Younasi. And we will now be joined by Dr. Thurow, who will talk about big picture implications of MASLD and its burden on the U.S. population.
So thank you all again for joining us. I'm excited to have you. I see some familiar faces among those. Of course, leading into the liver meeting this year, we wanted to highlight for you just the importance of liver disease. This, I hope, is not going to be news to you, but liver disease is recognized as a growing problem. By that, I mean the global burden of disease has been increasing year over year. And there are 4 dominant etiologies globally: viral hepatitis, both hepatitis B and C, but where there are increases that have been seen is related to steatotic liver disease. That's of a metabolic etiology, so metabolic dysfunction associated steatotic liver disease, or MASLD, as you've been hearing, is the new nomenclature. And Dr. Loomba will go over in detail how we arrived at that new nomenclature, and also alcohol-associated liver disease. So the big 4, hepatitis B, hepatitis C, MASLD, and alcohol-associated liver disease, are really dominating in terms of the etiologies of chronic liver disease and contributing a significant burden of morbidity and mortality, both in the US and globally. If you look at the statistics around cirrhosis, which is the more advanced phase of the disease, where individuals then are at risk for liver cancer and for liver-related death, it's estimated that globally there's 112 million individuals who have cirrhosis, and many of those individuals will not know it until they present with a complication. There's more than 2 million deaths related to cirrhosis every year, and about 1/3 of those are related to liver cancer, so a very important cause. And all of this is to say that we have a tremendous burden of disease, and that's got significant healthcare concerns, both from the point of view of being able to provide care to those individuals, as well as just the cost of providing that care. There was some estimates regarding the cost of caring for liver disease in the United States from 2016 that indicated that it's around $32.5 billion, and that number, I'm sure, has continued to rise. So we really are wanting to get the word out, because the key thing with liver disease is that it's often unrecognized until relatively late stages. And so bringing greater awareness to the individuals, to the population, is important, because individuals can then undertake measures to both be identified, be diagnosed, and then to ultimately undertake measures to prevent disease progression. Now, you've heard from our 2 speakers. We're highlighting the abstracts related to MASLD. So again, steatotic liver disease is a new umbrella term. You'll hear all about it, referring to fat in the liver. And it can be from metabolic dysfunction or it can be from alcohol. So both of those diseases can contribute to steatotic liver disease. But let's focus on MASLD, which you've heard from the two presenters, different aspects of why it's important and why we need to be bringing greater awareness to this condition in the United States. You've seen statistics, and many other studies have shown that about 1 in 3 American adults are affected by this condition. And a proportion of those individuals will go on to develop cirrhosis. They're going to need liver transplants. They're going to develop liver cancer. And all of that is potentially preventable, with the first step being to be aware of the diagnosis. So we need to be bringing greater awareness both to patients as well as to providers about how to seek out the diagnosis. And we need to bring greater awareness to the population around the things that contribute to MASLD. You've heard about the metabolic conditions, both obesity is on the rise, diabetes on the rise in the United States, and we know that those things are contributing factors to why we're seeing more MASLD now than we have before. So getting at the root causes in terms of our dietary choices, our sedentary lifestyle, these are all really important messages that we want to get out to the population and are really at our cornerstones for how we approach the management of patients who have MASLD. I think what was also highlighted by Dr. Younasi's presentation is the importance of this in our children and our adolescents. MASLD is also a disease there, which we have to be aware of. There's data suggests maybe as many as 1 in 10 children have MASLD. And you already have seen from the data you presented that some of those already have cirrhosis. So clearly, this is a disease that affects the entire spectrum of ages within the United States. We also know, as highlighted also by Dr. Younasi, that there's certain demographics that are particularly at risk, certain racial ethnic groups, individuals who are more socially disadvantaged. So we need to gain more understanding about that in order to bring greater health equity across the populations in the US. So I just want to highlight that you're going to hear a lot about MASLD at the meeting, but you're also going to hear about the other major causes of liver disease at the meeting. Alcohol-associated liver disease, also a really important entity, which we've seen significant rise in the past several years, as well as really the impact of viral hepatitis. That's sort of a good news story, but still one which is evolving. So I welcome your participation in the meeting. Not only will you learn more about those diseases, but I think you're going to hear about exciting developments in terms of diagnostics, as well as where we're moving with therapeutics. So important, I think, for us to understand that there are important, significant advances that are helping us in terms of trying to mitigate this burden of liver disease. But first and foremost is this awareness, the recognition that this is a very large, I hesitate to use the word huge when I'm talking about this, but the idea that we have an enormous burden of disease in the United States and globally, and everybody has to start becoming aware of their liver and what that liver health means to them, and how to seek out ways through their lifestyle to ensure their future liver health. Now I'm going to turn it over to Dr. Loomba, because he's going to walk you through the very important change that occurred this year. You already heard from Carolyn that you're going to see at the meeting that we see the terms NAFLD and MASLD used, NASH and MASH, because we are in transition. But a very important process happened over the past year and led to really a global move towards using new nomenclature to describe individuals who have what was historically referred to as fatty liver. So I'm going to turn things over to Dr. Loomba to walk you through that very important process.
Thank you, Nora. Really delighted to be here among all of you, and look forward to discussing it further with you. Next slide, please. So currently, we are in the process of changing where we stand currently from non-alcoholic fatty liver disease to metabolic dysfunction associated steatotic liver disease. And I'll discuss how we reached there and what was the process. Next slide, please. So there are several questions as we are thinking about a nomenclature. How do we really decide about a disease and how do we name that disease process? What are the key issues with the current naming and how can they be addressed better? And these were some of the things that all the experts or the participants or stakeholders thought about it as we came together to discuss these in our deliberations. What is the importance of steatohepatitis, which is the progressive form of fatty liver disease? And how do we assess these definitions and endpoints? How should the role of alcohol be accounted for, or whether we should not discuss that? How might name change impact disease awareness, clinical trials, and regulatory approval pathways? And can an alternate name reduce heterogeneity and allow for future advances? These were some of the key issues that we dealt with and thought about as we were thinking about renaming non-alcoholic fatty liver disease. Next slide, please. This was the process. A group of experts from all the world, representing more than 70 organizations, came together and decided that we should really tackle this issue. And the timing for name change was assessed, and series of input was gathered from these experts, which was independent of each other. And this process is referred to as a Delphi consensus development process. You ask a question, get a series of responses. Based upon that, you synthesize data and then get to the next question. So you can see to the left, I'm giving you various rounds. Over months this happened, and then key questions that were deliberated at each of those stages of Delphi process. And so we went from timing of name change for overarching term, whether to use non-alcoholic or fatty if it is stigmatizing. We also included patients and other stakeholders into this evaluation and assessment and received their input. Based upon that, an overarching term of steatotic liver disease came along. It was also decided to include the word metabolic because this is the genesis of this liver disease, because commonly associated with obesity, insulin resistance, and type 2 diabetes in our patients who develop progressive liver problems in the setting of metabolic dysfunction and metabolic syndrome. Under steatotic liver disease, then we provided different choices to various stakeholders and experts, and then eventually came to the terminology that I'll discuss in the next slide. Now, factors impacting definitions are listed to the right: alcohol and other etiologies affecting deposition of fat or steatosis in the liver. And then steatohepatitis was an important terminology to be retained because that really deserves a pathognomonic liver injury pattern that we wanted to recognize and want to keep that consistent. So all these processes led us to a definition that was well accepted universally in both adults and pediatric populations. Next slide, please. Now, the key acronyms to replace NAFLD, NASH, and overlap with alcohol were determined. So NAFLD is now called as metabolic dysfunction associated steatotic liver disease, or MASLD. NASH is now called as metabolic dysfunction associated steatohepatitis. So we're retaining the pattern of injury, which is the steatohepatic pattern. Now, we also recognized that there are some patients who may have an overlap between metabolic dysfunction and alcohol, and those are now referred to as MET-ALD. Next slide, please. This definition provides an affirmative set of diagnostic criteria for MASLD. There is near universal agreement to err on the side of being inclusive, minimize patient heterogeneity, and be adaptable to future insights. Simple, readily available, and easily measurable parameters are provided. The diagnostic criteria were also selected to align with cardiometabolic risk factors that are already well established and validated in other metabolic health disorders. And the set of criteria for adults was then submitted to a subcommittee of experts, as well as 5 pediatric hepatologists who looked and adapted them to the pediatric population. Next slide, please. Adult criteria are listed to the left, and pediatric criteria are listed to the right. This allows us to think about these metabolic dysfunction or metabolic risk factors as we are thinking about a patient who has hepatic steatosis in the liver. Next slide, please. So here you can see the umbrella term of steatotic liver disease. Then you go down to the left. This is individuals who have at least one metabolic risk factor and have hepatic steatosis. They are now classified as metabolic dysfunction associated steatotic liver disease, or MASLD. Similar to NAFLD, we divide it into 2 major subtypes. The non-progressive form of MASLD is termed MASL now, metabolic dysfunction associated steatotic liver. The progressive form of MASLD is termed MASH, metabolic dysfunction associated steatohepatitis. In the middle, we provide individuals based upon their alcohol consumption. So there's a range. If this is metabolic dysfunction predominant, then it's towards the left. And if this is excessive alcohol consumption, then that's towards the right. And we also provide weekly alcohol consumption ranges as well as daily alcohol intake in terms of gram. And this is useful as we reclassify our patients who are coming to see us who have hepatic steatosis on imaging. Alcohol-associated liver disease is also part of the spectrum of steatotic liver disease. And then there are specific etiologies for steatotic liver disease, such as certain medications, drug-induced liver injury, which may also be associated with steatotic liver disease. For example, methotrexate, steroids, imidazole. There are several medications that can induce steatotic liver disease. There are monogenic diseases that may also induce hepatic steatosis, such as lysosomal acid lipase deficiency, Wilson's disease, hypobeta-lipoproteinemia, as well as other inborn errors of metabolism. Then there are other miscellaneous disorders, such as hepatitis C infections, particularly with genotype 3, malnutrition, celiac disease. They may also be associated with steatosis in liver. And then finally, we have a group of disorders that are classified as cryptogenic steatotic liver disease in those who do not meet the other criteria. Next slide, please. A patient comes in who has hepatic steatosis on biopsy or imaging. Then we look for cardiometabolic risk factors, those criteria that are listed in pediatrics as well as adults. If you meet those criteria and there are no other causes for steatosis, you'll be classified as MASLD. So this algorithm can help a clinician identify which diagnostic category the patient belongs when they have or present with hepatic steatosis on imaging or on a biopsy. Next slide, please. We also looked at, and there are published data, and a lot of work has been done by investigators such as Dr. Fuckley and Zobair Younasi and others across the global group of investigators on NAFLD as well as MASLD overlap. What we are finding is that patients who were previously classified as NAFLD can be reliably classified as MASLD as well. And there is somewhere between 90 to 95% overlap within these group of patients based upon a series of publications that are coming forward. So what is the impact and interpretation of previously published data? We recently also wrote a corrigendum to a recently published AASLD practice guidance. This will be coming out in hepatology. This is the Journal of the American Association for Study of Liver Disease, describing some of these key caveats, key issues. Namely, that natural history of non-alcoholic fatty liver disease is very similar to natural history of MASLD, metabolic dysfunction associated steatotic liver disease. We believe it should have minimal impact on clinical trials associated with NASH among patients who have biopsy-proven steatohepatitis and stage 2 fibrosis or higher. Those patients will now be classified as MASH with stage 2 fibrosis or higher. What about impact on qualification of biomarkers? We also believe that will have minimal impact on the current classification as well as diagnosis and prognostication of biomarkers for detection of at-risk NASH, which is now classified as at-risk MASH. These are patients who would be candidates for clinical trials or pharmacologic therapy, because those criteria have not changed. This really allows us to move the field forward with minimal impact on currently established regulatory pathways for clinical drug development as well as clinical biomarker development in the field of MASLD. Next slide, please. Here I'm giving you one example where you can see that there is pretty significant overlap between MASLD as well as NAFLD. And this overlap is useful in understanding that the natural history of both of these disorders remains the same. Next slide, please. This allows for us to also have new opportunities for research. And I'll give you some examples of that. Next slide, please. Here we are looking at SLD subtypes, steatotic liver disease subtypes. We have group of individuals who do not have fat in the liver, group of individuals who have non-MASLD steatosis, those with MASLD, and then looking at MET-ALD. So they have combined effect from both metabolic dysfunction and alcohol, and then those with alcohol-associated liver disease. Now we're able to really tease out the effect of long-term prognosis on these individuals based upon their diagnosis at baseline. And you can see there's a pretty significant impact of how alcohol may contribute on top of metabolic dysfunction and how it increases the risk for all-cause mortality as well as hepatic decompensation in future. Several reports are coming along, and this has really ignited a new area of research where we're trying to understand the joint effects of alcohol, obesity, and metabolic dysfunction on the burden of chronic liver disease, cirrhosis, and its decompensation. This allows us to really look at patient wholesome in a way that we can assess all aspects that are happening in our patient, not just looking at people who are consuming little or no alcohol. Next slide, please. In summary, nomenclature change provides a new and unique opportunity to study the impact of metabolic dysfunction in liver disease. We're able to better quantify and understand and develop biomarkers, not only for MASLD, but also for MET-ALD and ALD. And now new cadre of biomarkers will be coming out that will differentiate different types of steatotic liver disease that we had not imagined earlier. This process has also brought together experts and organizations to build synergies to work in sync to combat liver disease globally. And I think this will certainly benefit our patients, and that's who we are planning on serving with the future iterations of these nomenclature as well as consistent development processes. Thank you.
Great. Thank you so much, Rohit, for that summary. There's already a question for you. So I'm going to now feel free, all of those that are participating, to put your any questions you have into the Q&A, and I'm going to try to get to as many as possible in the time we have. So Rohit, the first one is related to the question of whether the increased prevalence of MASLD, both in the US and globally, was that part of what was the driving force behind the nomenclature change. So maybe giving some insights into the history would be helpful.
Thank you, Nora. I think this is an important question. I think definitely it was an important reason for us to get together, that it's a major and a significant problem, not only in the United States, but globally, and this problem is rising. Therefore, we wanted to bring together a group of experts to have a common front and develop a nomenclature that is well accepted, and also can bring things together for future development of therapeutics as well as biomarkers that is consistent across different geographic regions and different continents. The increase in prevalence is definitely an important impetus for us to consider a problem and try to solve that in a consensus manner. So I think that was definitely one of the reasons why we brought the group together.
Great, thank you so much. Dr. Dr. Younasi, you're sitting there and I'm gonna just put you to work now because there's some important questions for you. In particular, looking at the relationship between, and I'd like you to try to address it in that adolescent children group, which you've kind of done a very nice focus on. But what is the relationship really there between MASLD and then the obesity versus diabetes? And then perhaps if you could also address, if you could, food insecurity versus food quality. And I'm not sure if you could really speak to, but that's also come up as being an important element and maybe particularly relevant for children and adolescents.
So the first question was about food insecurity and metabolic diseases, I think.
Yeah.
Yeah, in
Yes.
adolescents. So I mean, the food insecurity has been associated with NAFLD in the adults, for sure. But I think, the trajectory that Dr. Lee showed is going to be, the tsunami is going to be fed by kids. The global prevalence of NAFLD among children is probably underestimated. It's estimated about 10%. It's probably closer to 20%. We looked at the adolescent prevalence of NAFLD among adolescents using the NHANES database, and that prevalence was 24%. So it's very, very high and is going to progress. Now coming back to sort of relationship between the food composition versus sort of food insecurity, it's really they're all connected. They're surrogates of the quality. It's not only about total calories that you take, but also what is the composition of the food, the micronutrients, and other things that's associated with an environment that you actually are also seeing in that context of where food insecurity is higher. You will also have food deserts in those areas, but also activity deserts, I call them, where you don't have parks, you don't have situations where kids can actually get activity and exercise combined. So there's a combination of a lot of those things. When you look at a data set like this, it's hard to tease them out, but they all go together, and that's the important context. It's not always about how many calories you take. It's about what kind of food you take, what are the micronutrients in that food, what else is in your environment, what do you have available. For example, using plastic bottles repeatedly, for multiple uses is associated with obesity in both children and adults. And that actually can drive, because there are chemicals that seep out of plastic that can drive obesity, type 2 diabetes, and fatty liver disease. So it's all in that context. They're surrogate of each other.
Can I just do a quick follow-up question? I just want to make sure. I think the person who's asked the question was kind of referring to your data where there was not an association with diabetes, if I interpreted that correctly. So maybe you could just speak to that. Is there a difference in terms of the drivers of MASLD in children, adolescents, than say adults? And could you maybe try to interpret that aspect of your data?
So when you look at the table that looks at the NAFLD and non-NAFLD, there is certainly an association with metabolic conditions, as you would expect. When you look at the table where it looks at food insecurity and food lack of thereof, there is no difference in terms of some of these metabolic diseases. Of course, you can interpret that in a couple of ways. You don't have a large data set. You have 71 patients with this, and 600 with this. You need to have hundreds of thousands of individuals to actually make a good, assessment. That would be probably the easiest way. But there may be more to this, that for kids, that there are other things that can actually impact their liver that may not be obvious in terms of, diabetes. They may be young enough not to have overt diabetes, but they may already have some component of insulin resistance. So that requires a lot more sort of, studying.
Great. Thank you so much. Okay, Dr. Lee, you're asked the big questions, actually. Like, how are we going to solve this from the point of view of thinking about society or policy changes? So you really outlined this really, in a way, frightening trajectory in terms of disease burden, number of individuals, cirrhosis. I'm thinking to myself, there's no way we're going to be able to transplant our way out of this, as Dr. Younossi said, tsunami of disease that's coming our way. So what do you think we can do in terms of thinking on a policy basis, or maybe kind of in a bigger society approach to trying to reduce or change this trajectory?
Thank you so much for the questions. This is like a really huge questions, but so first of all, I want to say that it's important not to view our estimate as the exact numbers, but prediction is not the same as reality. But our study tried to provide like a possibilities of what would potentially be the burden of the disease. Given that there's no change in the clinical care for NAFLD, or there's no, and then the trajectory of obesity and diabetes and other metabolic syndrome remain the same or keep increasing. I think that if we improve our management of NAFLD or MASLD related comorbidities, and if we can develop an effective treatment for NAFLD or MASLD, then obviously the future would not be like so dark like what we are assuming for as what we see from our projections. So in terms of like policy implications, I guess as you mentioned earlier, that I think raising awareness would be the first thing, and I think that the collaborative work like between the primary care, because the starting point of identifying the patients and referring patients to specialty care start with primary care, and then if we have a close relationship, like working relationship with like specialty care and all of this health system, from identifying, diagnosing and treating the patients, I think it would help to reverse like the trajectory. I think there will be new data about treatment for NAFLD or MASLD at the conference, and there's also like some medications at phase 3 that show promising results. So we're hopeful that the future of like disease burden will not be as like as bad as our model prediction is, but that result is more like for us to understand what could be and to prepare, I think.
Prepare. I mean, I'm going to follow up on that, because I was asked the question as well as what I would like to see happen to change the trajectory. And I would fully endorse your recommendation that we really need to do a lot of education and increase awareness. Nothing would make me happier than every individual in the United States, starting in childhood all the way to those of older age, every time they see their physician are asking about their liver health, that they understand that the liver is this important organ, just similar to how they think about the heart as being so important. I want them to understand their liver is vital. And I want them to, whenever they're engaging with their physician, to be thinking about like, what is the status of my liver health? What can I do in order to be able to improve my liver health? And I see in my practice that when patients become aware that their liver is affected by MASLD, for example, it is a motivator. Sometimes they just haven't had the awareness. So I think I want every person in the population to be thinking about liver health, to understand what liver health entails through our lifestyle choices. And I would want the primary care physicians, as you highlighted, they're our front line. to really have kind of an automatic thinking about every visit of thinking about how do they assess that individual to see if they have liver disease. There's lots of nice, simple, non-invasive ways to do that. So I think that that's sort of the cornerstone of how we're going to try to change the trajectory. And then I think, as you say, we're excited about the new therapeutics, but first and foremost, we have to find the individuals, and we need people engaged in this idea that they can make a difference in terms of their liver health. That's sort of my wish. Okay, well, there's a lot of questions coming in, so now I'm going to quickly pivot a little bit here. Rohit, I think an important question. How do you use these terms now when you're talking to patients? So, you know, we think that from the scientific community, this has been a way to really advance and coalesce and bring greater understanding to this complex disease. How do we actually now share these terms with patients? How does that, what is your thoughts and recommendations around that?
Yeah, I think it's really important, and I can understand the genesis of this question. For example, if I have a patient who, drinks about 3 to 4 drinks per day and has fat deposition on ultrasound or imaging, comes to see me and has elevations in ALT and AST, and the patient is overweight or obese or diabetic, then I would say that you are here to see me because you have fat deposition in your liver and you have abnormal liver enzymes, that is ALT and AST. I believe that the cause of these elevations after your workup is related to both metabolic dysfunction, which is related to obesity and type 2 diabetes, but also related to alcohol. So in this setting, we will classify that you have metabolic dysfunction and alcohol-associated liver disease. And the way to treat it would be that we impact treatments for both of these disturbances or conditions. And I would recommend that you reduce alcohol use, and also we manage your metabolic dysfunction appropriately, such as exercise, weight loss, try to improve your insulin resistance. So I think if you don't get entangled and then take as it is coming, it's very easy to apply that to a particular patient. But I can understand where you're coming from, but this is exactly what I do in my clinical practice.
Thank you. So I'm open this up, but maybe, Zubair, I'm going to ask you, even though it's sort of directed, I think, broadly. I brought up the idea, like, we have to have our primary care physicians, helping us. They are the front line for us. But you and I both know that our primary care colleagues are they're overwhelmed with all of the checks that they have to do on a visit. So can you maybe speak to, things that we can do as specialists to really support primary care and think through how to make it easy for them to be identifying patients who have liver disease, and especially MASLD?
Yeah, no, I agree with your comments, Rohit, and from all the comments that were there. I mean, from my perspective, there are really 3 levels of awareness. The patient level awareness is very important. I think you brought this up, discussing with patients, and maybe at a broader sort of perspective, talking to patient groups, and so that there has to be awareness to patients, health providers, which is what we are getting over here. Really, the awareness has to be that these are metabolic diseases that are together. This is supposed to be, so our perspective about a single disease has to change. And I think this is going to happen with care pathways, where you have primary care and subspecialists, including endocrinologists, hepatologists, gastroenterologists, exercise specialists, in some form together. And maybe it cannot be always done under the same roof, but it could be done in a virtual setting where these folks actually work together. And we have to make it easy for primary care. First of all, they have to understand this is an important disease. That's our job, number 1. Number 2, that our nomenclature is very helpful here because it connects all these metabolic diseases together. What is metabolic dysfunction? Heart disease, metabolic dysfunction, liver disease, kidney disease, eye disease, all of these will come together. And then I go back to the policy issue, because ultimately we cannot actually treat this disease with just targeted treatment or drugs. This is not going to be a drug we can probably help a few patients, but not actually change the trajectory of this disease. And a survey that was done by the Global NASH Council and also with Jeff Lazarus, we looked at countries across the globe. There is not a single country that has a policy. And so this has to start at the World Health Organization recognizing MASH or NAFLD or NASH as an important non-communicable disease, similar to diabetes. That has to be recognized. And then every country, especially remember the prevalence of fatty liver disease or steatotic liver disease in the Middle East and South America is over 40%. It's 45%, in fact. So every region has to have their own policy, and then at country level, that's how we can address this. And it has to be at all levels. Primary care is a major driver of this. They need to be, sort of made aware of how important this disease is. And then we as specialists will have to make them, provide them with easy tools. A FIB-4, which is a blood test that will, a test that can be done with an algorithm. So to just find those metabolic patients that would be at high risk for liver disease, and then channel those patients to hepatologists, gastroenterologists, so that they can actually provide care. That's sort of my 2 cents.
Excellent. No, thank you so much, Savar. That's perfect. And it highlights AASLD recognizes that really this idea of partnering kind of in a global way to make this really at the level of WHO and others, where it's a recognized chronic disease that needs that full attention is part of our agenda as well. So thank you for highlighting the importance of that element in terms of advancing how we change the trajectory as we talked about. Okay, well, I think I got to all the questions. I want to thank all of you for those questions. I'm going to turn it back to Carolyn for the wrap up. Thank you all.
Thank you so much, Nora, and thank you to all of our panelists for their time today. We know in the lead up to the liver meeting, there's always a lot to do, so we certainly appreciate everyone taking the time to join us today. And we thank all of you for participating in today's webinar and for your wonderful questions. So again, if you have any follow-up questions after today's briefing, feel free to email me. You should have received my email in previous notifications about this webinar. We look forward to seeing you at the liver meeting in Boston or online on tlmdx.org. Again, I'll be following up with a recording of this webinar today, and look forward to future participation at the liver meeting. So again, thank you all so much, and enjoy the rest of your day.
Thank you.
Thank you.